I'm Sohail Sood. I'm a pediatrician in San Francisco at UCSF. I take care of mainly hospitalized children. And Teresa and I co-direct the global health, basically the pediatric portion of the global health training at UCSF. And as part of that, every year we have a lecture series of which Anu and Michelle and his colleagues have been presenting for quite a number of years now, and so appreciative for their insights. And for the trainees on the call, yesterday we talked a little bit about efforts to basically establish a pediatric residency program in Uganda, right? At one site with a few faculty leads under the auspices and support of a single NGO. Today, picture that, but scale it, right? So think about creating a pediatric heme-onc fellowship nationwide in the country of Vietnam with support of multiple faculty, both in country and from around the world, and supported by multiple NGOs. And that's what we'll be talking about today, is efforts to establish a pediatric heme-onc fellowship in Vietnam. And so fortunate to have leading that conversation, Anu Agrawal and Thanh Dao. Anu is Peds Heme-Onc faculty at UCSF Benioff Children's Hospital, primarily situated in Oakland, if that's still the case. Yeah.
Yeah.
And has extensive experience internationally. I think before focusing more on Vietnam, he was in sub-Saharan Africa, Botswana and Lesotho. And if I'm right, Thanh is one of the first graduates of the Peds Heme-Onc Fellowship, and not only that, but class valedictorian. So very excited to hear some of her perspectives on this work and her training too. So I'll turn the floor to you both, but excited.
Thank you. Yeah, thanks, Sohail. Really, it's our pleasure to present, and we really appreciate you all continuing to invite us. Dr. Thanh not only was in the first fellowship class, but she's also now runs the fellowship program through the University of Medicine Pharmacy in Ho Chi Minh City. So it's really a pleasure to have her give the perspectives from the Vietnamese side. So this is definitely interactive. So please, if you have questions, just interrupt. We only have about 35 slides, so we should have plenty of time for questions. So please don't feel like you have to wait till the end if you have a question. So I still have this picture is a little bit old, but I just like it because I think it really speaks to more than anything. In our focus has always been on how do we best partner. And we just finished the paper, which was really excited about how things have improved over the last 5 to 10 years in our program. And we really highlighted accompaniment, where the goal for us was really to try to be there to provide support, but then eventually pull out. So I think Thanh can also speak to that part. And it's definitely been a work in progress. So each year we do these talks, and I think we see improvement. I think doing the talks helped us just kind of recenter on the fact that we are making progress, although it's definitely, these are all labors of love and they take a long time. So as part of our efforts, we created an NGO called SIFO, Southeast Asian Pediatric Hematology Oncology. And one of the reasons that we did that is that we wanted to be really inclusive. A lot of the international programs, especially at the subspecialty level, are very single institution focused, and we just didn't have the resource time to be able to do that. We also, from the beginning, partnered with colleagues from University of Texas in San Antonio. And so we were really wanting to collaborate with anybody who is in Vietnam. So that was a really important thing for us. And getting memorandums of understanding through all of our institutions, we've been doing that, but it's a bit challenging. And we also wanted to focus on the region because there's a lot of best practices that can be used across institutions and across countries. And there's definitely very differing levels of income and also expertise. If you look across the Southeast Asian region, you have countries like Singapore who are really leading the way, and then you have countries that are doing really, really well, like Philippines and Thailand, and then you have countries that are doing very poorly, like Laos and Cambodia. And so for us, we wanted to really think about how we also eventually regionalize beyond just Vietnam. But at the beginning, we were really focused on how do we improve care for children with cancer and blood disorders in Vietnam. So I have about 15 kind of intro slides, and then Thanh will spend the rest of the time talking about the training program, and then just also focusing on how do we as a program always think about doing what's best for our colleagues in Vietnam, and how do we partner best with them, and also that it's pretty dynamic, that we're always thinking about ways to improve the way that we provide training, and I think the COVID pandemic also highlighted that need for adaptability is so important in a lot of these programs. So just as background, I think most of you guys probably know this, that childhood cancer survival in high-income countries like the US and Western Europe is really pretty excellent now. About 75 to 80% of children in our settings will be cured of their cancer diagnosis, whereas in low-income countries, it can be as low as 5%. Hopefully, it's now more in the 5 to 20% range. Also, the majority of children who are diagnosed with cancer live in low and middle income countries. So for us to make incremental change now in a setting like the United States is very difficult. Often the trials we're looking at, we're trying to make 2-3% changes, but in a low income setting, you can make quite a bit of impact in a short period of time. So that's kind of the selfish part of it for us. That's kind of our hope, is that we can improve over 5 to 10 years. You can go from 10 to 20 to 30 to 40%, which is a significant improvement in survival. So the other thing is that if you look at the pyramid distribution of age, a lot of the low and middle income countries have a much higher population that's younger. And also now many of the countries have gotten over the under 5 mortality from malnutrition, infection, diarrheal illness, pneumonia, etc. And so we're seeing children who are able to be old enough to then get diagnosed with a secondary problem like cancer. So it is a really great time. A lot of the countries now are also developing the infrastructure and desire to be able to try to treat these more specialized illnesses. And then there's the work that's been done in the Western setting, United States and Western Europe in particular, where collaboration and a stepwise approach has shown time over time, trial over trial, decade over decade improvement in survival. So ALL is acute lymphoblastic leukemia is really for us the hallmark diagnosis. It's the most common cancer in children and was universally fatal back in the 60s. But with collaborative trials across nationally in the United States as well as internationally, that cure rate now is approaching 85 to 90%. So that's for us a really great model that hopefully is something that can be replicated in low middle income settings, both regionally, nationally, as well as internationally across countries. And I think one of the challenges that we don't really know what the survival rate is in a lot of developing countries. We assume it's very, very low, but we don't really know for sure. This is actually an old slide now. This is back from 2008, but I'm not sure it's that different now. But you can see as the government spending on health care increases, the 5-year survival for childhood cancer goes up. So you have on the right upper, you have all the high income countries, and then going into the high middle income countries, and then low income countries. So this is quite a bit old now. This is really the last data that we have about Vietnam, where you have about a 5% survival, but this is now, it's very dynamic there. So this is 15 years ago. We imagine it's more in this range, but we just don't have that data yet. So one of the first things we did when we created the NGO, which I think was somewhat painful, and it always is painful to go back and do a vision and mission statement, but it's really important because it really grounds your work and it helps keep you grounded in what your initial goals were, and then you can always change them as you want. So I'd already, in a previous slide, showed what the vision was. And then our mission, we really wanted to think about how do we improve upon the workforce that's specifically trained to take care of children with cancer and blood disorders. How do we foster leadership within Vietnam so that we could create a self-sustaining program? And also the need for multidisciplinary care is really, really important. So not just fostering pediatric hematology oncology, but how do we create a model program that could be used across other subspecialties? And also within CFO, we wanted to really be focused on multidisciplinary care. And so as part of our initial board, we did have pediatric hematologists, oncologists. We also had leaders in oncology nursing, as well as oncology psychosocial care. So it's really important for us to think about how do we provide multidisciplinary care, which we somewhat take for granted here. Supportive care too, we somewhat take for granted here, but when you work in settings where you don't have as much infrastructure, you realize how important that is, that taking care of ALL here seems relatively straightforward. And like I mentioned, the cure rates are very, very high, but in the low middle income setting, ALL is often one of the most difficult to take care of because of the lack of the supportive care. So children die from infections, they die from problems with blood counts, things that we just don't see here. So that's also really, really important. And then really focusing on how do we collaborate across internationally. When we went there, there was so many organizations that were working in Vietnam in different parts of the country, and we wanted to really think about how do we work together rather than be duplicative, and also create confusion, because we may come in as a group and say one thing and another group comes in and says another thing, and then it's up to our Vietnamese colleagues to try to figure out how do they interpret that information and what do they take from that. And that we found very, very confusing. So we really wanted to focus on building an international collaboration where we could all work together. Also, the other really important things to do in parallel is start to develop research initiatives, because that data I showed about decade over decade improvements is really due to a background of research that's going on. And so all the fellows, which Thanh can talk about, have done quality improvement projects, some of which have been really, really great, and even in a short period of time improved different things for children with cancer. And then finally, one of the really important things is creating sustainability through advocacy, local resources, and there's a long history of doing that. That's made international programs successful. So it's a puzzle. You have a lot of pieces, and you can't focus on all of them all at once, but you may focus on one or two things, and then you build collaborations and you start to be able to work on more and more of these different parts. So for us, we really initially focused on international support, education and training, the pediatric cancer unit, and then some of these others have come along the way. This is another slide that kind of shows that, a more recent slide, just how many different steps there are in terms of taking care of children and adults with cancer. So there is a need for outreach, which we haven't yet focused on, but is definitely a goal for us. We've been really focused more on the tertiary care aspect, where children are coming to the regional centers in the north, central, and south of Vietnam, creating a twinning program, creating certification processes to qualify centers as well as practitioners, and then developing national standards to take care of these children. So historically, a lot of the work in pediatric cancer has been led by St. Jude, and they've done really an amazing job developing networks as well as training. And it's really been initially twinning at the institutional level, or maybe at the regional level. So they started in a center in Recife, Brazil, which I'll show on a later slide. And then subsequently, then they started to develop networks. Their probably most successful network has actually been in Central America, which I'll show as well through an organization called HAPCA. They also initially started training pediatric hematologists, oncologists at St. Jude in Memphis, which I think was a really successful way. And those trainees would then go back to their home country and kind of lead the efforts. That's difficult to replicate because it takes a lot of resources. And then the other challenge is to find people who want to come to the US to train and then go back. There's often a lot of brain drain with that too. People don't want to necessarily go back to their home country. So that's been an initial successful model, but it's also been very insular, that it's been very limited to St. Jude, and it hasn't really involved a lot of other organizations and people that have been wanting to do international work. As part of that, they also created a repository for training materials called Cure for Kids, and a database, which was previously called POND, but now it's called SJ Cares. And there are many other organizations, and I think this is continues to be a struggle for us is how do we best involve all of these organizations and work together. So this is from Recife, Brazil. I think it's a really good example. So they started going there a long time ago now in the 80s, and they had data too, which was really important part. And so initially you could see that about 20% of families abandoned therapy, about 20% relapsed. The toxic death rate was actually not that high because the intensity of therapy was not that high. And so overall they're better than a lot of low-income countries. They had about a 50% event-free survival. But then with the resources, they were able to decrease abandonment significantly, relapse significantly. Initially, there was increased toxic death rate because the therapies were more intensive, but with improvements in supportive care, that improved over time. And then overall, they were able to show a significant improvement in event-free survival over each of their time periods. So that's a really great model. So we've always had that in the back of our mind as our ultimate goal. This is another really important slide, I think, just showing that it's a multi-step process, but also that you want to really think about how do you over time step away. So you as an international agency may be initially providing a lot of the financial support and also just a lot of the even mental, physical support, but over time that really needs to go away and then should be more supported by local governmental agencies as well as local grassroots organizations. So we're probably here in the 2 to 3 year time frame, and so we're really thinking about now how do we start to get more local resources. So this is AHOPCA that I mentioned. So they initially started with twinning at the local level within countries, within cities, and then eventually regionalized. And that was a lot due to local leadership too, as those people began to know each other and wanted to work together. Also, if you look at it from a size standpoint, if you look at the entire Central American region, it's somewhat similar to Vietnam as a whole too. So we thought that was a really great model for us to think about maybe one of these countries as a region within Vietnam, and then eventually partnering across regions, North, Central, and South. The other thing they did that was really important was thinking about one cancer diagnosis at a time and unifying treatment protocol, starting with things that are a little bit easier, where the protocols may not be as intensive, and then working towards things that are more difficult and require more multidisciplinary care. So you can see leukemia, ALL, which you may hear think about it, oh, that's the simplest to treat. They didn't start with that because you really need a lot of supportive care to be able to do that successfully. So why did we initially choose Vietnam? I think some of it was serendipity, some of it was just happened to be collaborations. Ultimately, it was a good choice because it's a very dynamic place and things are improving really rapidly to have the infrastructure to provide pediatric subspecialty care. After sub-Saharan Africa, I spent a little time in Ethiopia, and we were trying to build a pediatric oncology program there, but they hadn't really tackled under 5 childhood mortality. And they didn't really have enough country level resources to really do a great job. So it wasn't the right time, but it's very different in Vietnam. You still have a lot of the challenges. So you have a large number of children. You have a really overwhelmed system, but you have a lot of opportunities with improved infrastructure. You have the thing that we always highlight when we go there is that at every level of the hospital, the physicians, nurses are incredibly motivated to take care of these children and to improve outcomes for them. And then for us, there was a big opportunity because there was a lack of data and there was really a lack of any training program. There still is, I think, somewhat a misconception of hopeless terminal illness, and that's part of overcoming that misconception is what really helps to develop grassroots organizations and local resources. So I think that's something that is definitely improving with time as they build new hospitals and that misconception starts to go away. So just to kind of highlight the things that we really focused on as our initial triad, one was the staff. So thinking about how do we improve pediatric oncology training. For us, we were initially thinking about the fellowship program and training physicians, but as I mentioned, it was also really important for us to try to think about how do we train nurses as well as also develop social work program, all the other things that are really important, not only for taking care of children, but also providing local resources to decrease abandonment of therapy. Lack of data, of course, you really need to have some way to look at incidence and outcomes over time, and then developing resources. So this is a picture from one of the hospitals in Ho Chi Minh City in southern Vietnam, Children's Hospital number 2, that was really designated to be the leukemia hospital. And as you can see, it's very crowded. So again, like I think for us, we spent a lot of time at the beginning in the development of our organization, really taking a stepwise approach to what are we trying to do and how do we do that, thinking about the short, middle, and long term, and always really going back to our mission and vision statement, and then thinking about how do we do that, and then what's that going to look like over those periods of time. And we're still in this process. Like we've started to do some of these things, but we still have a long way to go to really get to outcomes. So same thing here. We're probably somewhere now between step 2 and 3. So, and this has been over now since 2016. The fellowship training program started in 2018. So we've made progress, but it definitely takes a lot of time. So just always keep that in mind. So this was kind of our initial triad. Based on the prior work, so developing a twinning program, thinking about training and curriculum building, and then QI and research. And we've kind of modified this, which I'll show in a later slide, as we've been in Vietnam and thought about what makes the most sense. And all the twinning programs maybe are a good model. I think things have changed a lot as how best to do that. And I think actually the COVID era has helped to make us adapt to, and I think the biggest benefit of COVID has been able to do this. What we're doing right now is be able to meet from and have people from all over the world join. And that's, I think, changed a lot of how you actually envision a twinning program too. So we kind of changed to this model where the training program, data management were important, but as far as twinning, it was a little bit different. We really wanted to then focus on how do we provide unified treatment protocols. And across those 3 things, the hematology training program, which Thanh will talk about, we began in 2019. So the first class graduated in 2021. That was 6. Data management, we had gotten some funding to develop data management across the 3 regions in North Vietnam, in Hanoi, in Central Vietnam, in Hue, and then in South Vietnam and Ho Chi Minh City. A lot of that work got postponed or put on hold because of COVID. So we're re-engaging the hospitals to develop data management, mainly with the goal of trying to understand cancer incidence, abandonment of therapy, outcomes, toxicities, etc. And then we struggled a lot with unified treatment protocols. As I mentioned, a lot of the centers were getting information from different places, and we're using European protocols and American protocols and some combination thereof. So we actually developed through COVID a bone marrow transplantation and cellular therapy consortium. And we did this somewhat hesitantly because we didn't want them to focus on the most intensive therapies, but they really had a desire to do this, and there was already centers doing transplant. And that has been a really successful way to get representation from all the regions and all the main hospitals, and really think about unified treatment, standardized operating procedures. And so we're aiming to do the same for pediatric hematologic malignancies like leukemia, as well as solid tumors. It's really a way to engage now the 14 hospitals that take care of children with cancer across the country. So there's just one other slide to show kind of where we are. We're still relatively early in this process, so some of these deliverables are still in progress, and then we're starting to work on 2 through 5. It's just again to show like the time frame is very long for many of these projects. And then I think this is the last slide for me. As far as kind of the overall theme of accompaniment, we wanted to really think about how do we create a structure that is really focused on being Vietnamese led, with us as international stakeholders or mentors providing support, and you know, what's kind of our exit strategy. And we also wanted to think about what's been successful in other countries like twinning to an extent, and then also what's been successful in Western Europe and here as far as improving cancer outcomes for children over time. And so we thought about all of those things and created a model. So here there are collaborations between universities like UCSF and others who then work together to develop workforce, as well as to work together through collaborative organizations like for us, the Children's Oncology Group, which was initially housed at CHOP, Children's Hospital of Philadelphia, UPenn. It's now not, but that was really that was kind of a model for us to use UMP, University of Medicine Pharmacy in Ho Chi Minh City, because they were very willing to help us with developing many of these aspects. And then there's also a local pediatric oncology consortium already called VIVA, where our Vietnamese colleagues would go, and then a local within country consortium similar to Children's Oncology Group called VPOC. So how could we utilize some of those existing pieces and then provide support as an external advisory board? All right, I'll pass it on to Thanh.
Yeah, thank you, Anu. So I will talk a little bit about the overview of the fellowship training program in Vietnam. So with the help of our international faculty, the program was built in 2018, and we had a first class from 2019 to 21, and I'm very successfully and luckily the first graduate in this class. And now we have the third intakes with the total number of the fellows is 10 now, and we hope that in the next few years we can get self-sustained, and all the lecture will be instructions mostly by Vietnamese, but actually we also need the help of international experts, because a lot of subspecialty need to be developed. Next. Okay. Yeah, and like Anu said before about the national construction, Vietnam is a very long country from the north to the south. So in the middle, we have the name of the institutions can care for children with cancer from the north to the south, and we have the support from the Ministry of Health and also University of Medicine and Pharmacy to develop the CK2 training program, or fellowship training program, with the support of our international faculty. And we also have the support of the global organizations like WHO, Children Cancer International, C4, Viva Foundations, and also many NGO organizations to support psychosocial to our patients. Next slide. And the National Pediatric Oncology Consortium aim to have plan for the data collections, with sharing the protocol for therapy and supportive care, and research to understand the unique response of Vietnamese children. And we have one annual meeting in Health in Hue, and we come together to share our experience in taking care of pediatric cancer in its regions. Next, please. And Dr. Anu already said about the pediatric bone marrow transplant task force. This task force was established since 2020 during COVID, and we have totally 7 centers across Vietnam can perform or plan to perform the bone marrow transplantations for pediatric cancer. And each of the institutions have the representative doctors and nurses, and we have one meeting every month to share our experience and listen to the lecture from our international faculty to establish the basic knowledge and advanced knowledge in pediatric bone marrow transplant. Next, please. From 2020 until now, we have more than 7 meetings, and we have the support from many experts, Dr. Michelle's competence, UCSF, Dr. Anu, UCSF, Dr. Julia Palma, Dr. Dr. Horns, Dr. Jess O, Dr. Lauren Falker, Nurse Linda, Nurse Nancy, and Nurse Idram to help us give us a lot of lecture in the task force and helping us establish the pediatric bone marrow transplant task force.
I think here too, like a lot of our initiatives, we thought about multidisciplinary care. And so although many of the lectures were from physicians, we also had cell therapy technicians and nurses and others who helped. And it's been very multidisciplinary as far as who comes to the meetings, which is great.
Yes. And for the fellowship training program, actually it's based on the foundation knowledge of pediatric blood disease and cancer, together with 4 longitudinal threads, clinical skills, research, quality improvements, and professional development. So for foundation knowledge, pediatric blood disease and cancer actually is based on America for Pediatric. And with 4 longitudinal threads, clinical skills, the student were trained for all aspects of the pediatric blood disease and cancer disease. And we also need to complete a research project during 2 years of the training program and complete quality improvement projects. Actually, we have in the first class, we have 2 teams. One team develop SOP for bone marrow aspiration and biopsy in Children's Hospital number 1 to reduce the cost and time of bone marrow biopsy. And another team did quality improvement projects to reduce the traumatic IT for the patient with leukemia in Children's Hospital number 2. And all of us have one research, and we're for the 5 people in the first class, we complete the research project and present in the final examinations. And some of us also have our present. Some of us also present in the international meeting and national meeting. Just one person cannot complete because he could not collect enough data because of COVID. Can you go to the next slide? This is also the showing some nurse training doing by international expert to our nurse on site and during COVID it's online. Next. And with the fellowship training program, there are 4 core principles. Firstly, the patterns after America for Pediatric requirements, and it is in English, the language of international meeting. So it is also very important. So after complete the course, we can using English to like present in the international meeting to show our data. And the program needs to fit 2 years footprint of Ministry of Health CK2 footprint. And partnership is very important to the program. And this is for until now we have the 3rd intake of the program, and we also aim to expand the fellowship training program to Hanoi and Hue, and now we started to prepare a document to submit to the Ministry of Health, and we hope that in the near future, where university can establish the training program in there.
It's I didn't put it in the background, but it's somewhat regionalized in Vietnam between the north, central, and south. And so that's why we initially started with the training program through UMP and Ho Chi Minh City, focused on just Ho Chi Minh City, and with the goal eventually to expand across the country. And so again, I think having the ability to do things by Zoom has been really helpful, because the initial training program had international faculty going over 1 week out of the month. We gotten grant funds for that. And it was going to be pretty labor intensive, but focused just on Ho Chi Minh City. So now we're able to expand. It's going to be challenging, but we will have faculty that go there in person. We just have to figure out how they'll spend their time across the 3 regions, but definitely doable.
And next, please. So with the Vietnamese perspective, we also have many good opportunity because this is the first pediatric hematology oncology CK2 program in Vietnam. So we have many information, many knowledge that we can intake. So this program, the international faculty teach in English. So it's very difficult for Vietnamese students at the beginning because our previously we already trained in Vietnam, so now we moved to English, but with the times our English improving, and now we can communicate or discuss in case easier. The program fit 2 years footprint of Ministry of Health, so at the end of the program is qualified as a CK2 certificate for pediatric hematology oncologists by our Ministry of Health. So it's a good point. We got the certificate from our Ministry of Health. And we have a huge support from international faculty. There are more than 48 international faculty willing to teach us, even on-site or online. And the list of the international faculty get longer and longer. And we're also very lucky to have support from many organizations all over the world, from Kencham, Vietnam, SciOp, Sanchus, UCSF, Global Health Program, Texas University, Centennial, and etc.
I think the English teaching in English was definitely challenging at the beginning, but it was remarkable how much progress the trainees made over the 2 years. And then I think the other really significant thing we saw was that the way that we teach is so different. And then I think that was probably the most positive feedback that we got from the first fellowship class, is that we took a very analytic approach, whereas it's very more still the traditional rote training there. And I think that has really helped the fellows really think about how to approach patients, have a broad differential and then narrow. And I think that way of thinking and modifying that way of thinking, I think, was the most important part of the fellowship training. And you really saw over the 2 years how the fellows began to be able to approach patient in a way that's much more patient-centric than maybe just book-centric. So I think for me personally, I think that was, I think, the thing that I saw that was best. And it's also just, as we see the initial fellows being the leaders there to then be the faculty that provides the training, we thought that was really, really important that they foster that mode of learning and teaching. And then that, I think that will be really helpful in future.
Yes, I agree. And we also have many difficulties in this training program because we still lacking of national faculty. So we still need to have a international faculty to continue our training program, because after graduates, we understand the broad knowledge of pediatric hematology oncology, and we need time to develop our subspecialty. And some, for example, some specialty needs for development in Vietnam, like radiation oncologists and neuro-oncologists. Yes, English ability also challenging, and like Dr. Anu says before, with the time English will improve, but we need to convince other fellow that don't worry to join us, because your English will be improved with the times. And for the research projects, we still need the support in collecting the data, analyzing the data, and publishing the data. Because during 2 years periods, there are lots of things the fellow need to do. Study, doing the research projects, doing the QI projects. So traditionally, we need to do by ourselves. However, with this program, we need to have of other people to collect the data and like collaborate with people to analyze the data, and also get a help of international faculty to publish our data to international journal, and that's very important. Next slide. So in the future, we hope that we will have the sustainability of our CK2 program, and we hope that the number of fellows and national faculty will increase. In the future, we can do cancer registry. We can start at the hospital base and can expand to national base cancer registry, and improve or increase the number of cancer research in extender. And we could address some difficulties issue in our country, for example, drug shortage, or lacking of diagnostic tests or treatment follow-up tests in our hospital. And with the data, we hope that we can reduce the abandonment rates. And with the national construction, we hope that we will have a national protocol for pediatric cancer in the future.
Just questions for you, Thanh. Do you feel that within the UMP structure, you being the local leader of the program now, that you get enough support? Like, how do you feel that is? Because it's still a relatively new program, and there hopefully will be other pediatric subspecialty programs that follow, but it's hard to be the first, I think.
Yeah. Yes, this is the first program follow like American Board Pediatric. And we understand that it's different from our traditional program, the CK2 program. And to convene other UMB faculty to do the same way like this is also challenging, because each of their specialty, for example, cardiologies or GI, also need a lot of subspecialty experts. And to tell it to our university, we still lacking of subspecialty in each of the subject, each of the CK2 program. So to do that, we also need to expand or increase the number of national faculties and subspecialty, and it is very challenging.
Yeah, it's a good model, but then to do it across subspecialty is not easy, and then do it across regions in Vietnam is also not easy, because we were able to get Ministry of Health approval for this program specifically in the southern region, but we have to do the same steps, get Ministry of Health approval in the central and northern regions, and then also you have to develop a partner. So similar to University of Medicine Pharmacy in Ho Chi Minh City, we have to develop a similar partner in Hanoi and Hue as well. I think we have those partners, but it is definitely challenging. There a lot of programs develop initially with support from the Ministry of Health, and that's just something that's not been possible in Vietnam for us. So that's definitely kind of a long-term growth and sustainability issue. Can you speak a little bit to, I think the thing I worry about too is that you all aren't necessarily have as much say in where you go, and so I do worry that the fellow trainees, may get placed, back in their home institution, and are they going to be able to utilize the fellowship training or not? I don't know what
Sorry, I knew I couldn't hear well.
No, I was just asking you what your thoughts are about some of your trainees in your class and other classes may get placed back in other hospitals or in settings where they aren't necessarily going to be taking care of children with cancer. It's because that some of them aren't able to. It's decided for them where they would be placed. So I worry about that too, is that are they going to be placed where they're actually going to be able to utilize the training?
Yes, I worry too, but there's still some of the fellow after graduate, they become the faculty, or they working under the center and they care for children with cancer. For some of the fellow, they are not working in the hospital caring for cancer. They can like recognize the diagnosis, early diagnosis for cancer, pediatric cancer, and can transfer that information to our other colleagues in their institutions. And that's also very good point of the program. Even they are not really working to treat patients with cancer.
True. Yeah, they can help with at the provincial hospital level. They can work with the development of more awareness about early identification of pediatric cancer diagnosis, which is still a big challenge within the rural areas for sure. Yes. That's all we had. This is again old. These are old, but still applicable. UN WHO goals for the decade. So we've kind of worked on some of these, but I think across the years, they're all things that are important to be done. So we have time for questions if anyone has questions for myself or Dr. Thanh. We're very fortunate. I mean, Dr. Thanh spent time here with us. Also, her English language skills are really excellent. And I think that the other fellows all kind of worked up to her level over the 2 years. So, and so we're very fortunate to have someone like her be there to help lead the program now.
That's so wonderful. Thank you both very much for sharing. Thank you, Tiffany, for putting an evaluation in the chat. If all could take a moment to fill that out, that would be great. And the floor is open for questions. I'm happy to start with one for Dr. Thanh. At a previous session centered more around technology, we had kind of discussed how sometimes the junior trainees end up knowing more than their mentors and their faculty. And that seems analogous to you being trained in an emerging specialty in Vietnam, where perhaps some of your more senior colleagues don't know as much about it, especially in country. So I suppose, what's that like for you? And how does that work, kind of thinking through teaching and mentoring those who might be more senior than you, who have interest in this?
Yes. So for my understanding, so there are many of senior colleagues. They not have like training like us, right? And actually, in Vietnam, our colleagues are very open and they willing to get the new information, get the new knowledge. So we can discuss with our colleagues, and we are open to share our knowledge. Even that in our training program, not only the fellow can get information, get the knowledge from our international faculty, we open the class to other colleagues from other center across Vietnam, from Hanoi to Hue to Saigon, to attend the class, and they willing to attend the class to get information, get the new knowledge, and very eager to join us. Even they are not fellow, they just want to know more about the pediatric cancer. So this, I think, is not very difficult to deal with that.
I think that speaks, that's a great question, Sohail. I think it speaks to just the time spent, and that was largely due to our colleague Chach Asanasan, who started going, he's at University of Texas, San Antonio, he started going in the early 2010s. He's been going for more than a decade, and really relationship building, which I think helped us a lot with trying to develop something that's a little different. We also had, at the time, Dr. Tuan, who's the head of the University of Medicine Pharmacy, who was really very forward thinking and how he wanted to see training in future looking like in Vietnam, really replicating the US and Western Europe. And so we've been fortunate that we have had those people who have been very forward thinking. And as Dr. Tanan said, which is very true, is that even the older faculty there are generally very, very willing to try to work towards a new model, because I think there's general recognition that that's going to be an improvement for training and care there.
I'd just like to say this is such an incredible and inspiring amount of work and program that you've implemented in fellowship. Just congratulations across the board, and also to Dr. Tanan in your new position as the fellowship director. That's really exciting. I think, Brian, do you have a question? I saw you come off mute really fast. I want to make sure you have a chance, and then I can ask my question.
I do, but you should ask your question first.
It's okay, Brian, please.
Okay, I guess, yeah, I have just a couple questions. I think one, in terms of transplant logistics, I know that it sounds, I'm just wondering from your perspective, like, is First Vietnam, is it part of the matched registry? And I was just wondering, like, if it wasn't, kind of like, what's the donor selection for transplant purposes? Like, is it typically autologous? Is it like haplo, etc.? And then my other question is, I know that like a lot of focus right now is on the infrastructure behind like treatment for these cancers, but I was just wondering how much support there is for other aspects of care, such as fertility preservation, psychosocial support, etc.
Yeah, those are great questions. So maybe I'll answer the second one first. So yeah, we've been very fortunate that we've been able to develop the other multidisciplinary programs in parallel. And so social work was something that was highlighted pretty early on as really important, both to us as well as our local colleagues there. And so there's been a lot of efforts to develop more social work program. That was also highlighted by a patient who was undergoing transplant who committed suicide. And that, I think, really brought really to the forefront the importance of having enough support if you're going to do a transplant, not just from a medical standpoint, but from all the other multidisciplinary aspects to ensure you're supporting the patient and the family. And so I think all the hospitals have been very focused on trying to do those things in parallel. Some of the other specific things like oncofertility have not yet really been addressed. I think those things are important to have in the background, though. And then as far as the donor selection, yeah, that's an excellent question. So the slide that Dr. Tanan showed with the BMT consortium speakers, we've been fortunate to have many international experts who've helped develop transplant programs. And so there's many different ways to think about it. One, some of the programs as they initiate transplant will do autologous transplants first. So things like for solid tumors where you may be doing high-dose chemotherapy with stem cell rescue, which is a relatively more straightforward than doing an allogeneic transplant. And then you don't have to worry about the donor selection. But then secondarily, in general, up to this point, it's been if there is a matched sibling donor, because there is not a local registry. We've been working with a German organization to help us with development of a local registry, which I think will be really important. But what's been done by Lawrence Faulkner as others is really starting to focus on haplotransplant as a method, because you have available donors, parents, siblings, in a setting where you don't have a registry. So that's kind of been our focus so far.
Maybe I should give some context for this next question. I'm one of the critical care physicians at the San Francisco campus, and I heard, that there's a lot of, and this kind of piggybacks on Brian's question, a lot of effort now to expand the supporting services that go into the holistic care of these complicated patients. What are kind of the ICU capabilities and capacity? I think at least in the US, like 40% of HEMONC patients will end up in an ICU at some point during their treatment course. So just curious kind of what those supports are as well.
Yeah, support. So ICU is so very important for the patient with cancer treatment. Some of the hospital in Ho Chi Minh do not have ICU, but mostly with the children, the General Children Hospital, where the Pediatric Hematology Oncology part there, we have a support of ICU departments. So they're challenging with Oncology Hospital, which is adult hospital, and pediatric part just was most part on the Oncology Hospital. So there are some critical case they need to transfer to other hospital, and that's still happen in Ho Chi Minh and another hospital in Vietnam.
We did in one of in the pre-COVID, we brought over a multidisciplinary team, including critical care specialists, critical care nursing specialists, and that's definitely an area that we've been trying to improve upon, because there's, like here, I guess, but probably more there's definitely challenges between transfer of care and being willing to take patients in the ICU too. I think there is a lot of pushback, partly because of the misconceptions about the outcomes there as well. So that's definitely something that needs improvement over time. It's getting better, but it's going to take a concerted effort. It's hard, right? Because we've been focused on trying to not intensify therapy too much, but there is a desire to provide the Western standard of care. And so we're trying to be respectful of that and provide as much support to do that safely.
Well, if it's something you're interested in pursuing, I have worked with Asia Golnick at St. Jude on some of the like Proyecto Yuvat and trying to get centers mainly around oncocritical care. So let me know. I'll put my email in the chat, and if you
guys that would be great. Yeah, we can connect you with our colleagues from UT San Antonio that went and to get their assessment. And I think that would be a great thing to work on together, trying to identify partners there.
Making connections, facilitating. I'm excited to see where all these collaborations go. Well, thank you so much, Anu and Dr. Thanh, for your insights and more importantly, your work. It's very exciting to see this continue to grow. For Brian's sake, as Dr. Anu has given this talk, year after year, he's brought on different folks to talk as well. And I believe in 1 year he did bring in social work, and they focused a little bit on palliation, and another year nursing too. So really interdisciplinary team doing great work in many facets. So again, thank you.